Good afternoon, all. I'm Sandeep Sharma. I'm an interventional radiologist at University of Minnesota, and thank you for the invite to talk about liver-directed therapy and the role of interventional radiology for the management of neuroendocrine tumors metastatic to the liver. So the goal of this talk is to have you guys aware of what the embolization techniques, like the embolotherapy, means in relation to the metastatic disease to the liver, and then compare some differences between the various techniques that we use to treat such patients, and recognize the clinical scenarios where one treatment may be better than the another. So these are the NCAN guidelines from 2024. There hasn't been any change in 2025, the updated version. So the indications for hepatic artery embolizations, which means getting into the arteries which are supplying the liver, and the neuroendocrine tumor, like a normal liver gets about 70% of the blood supply from the portal vein and about 30% from the hepatic artery. And the tumor itself, when it's metastatic to the liver, it's almost entirely getting its blood supply from the hepatic artery. So we are sort of utilizing that to embolize the hepatic arterial side, which affects the tumor and spares the normal liver. And there are other techniques we use to spare that too. So it's indicated in if these patients are symptomatic despite medical management, and if the hepatic disease, the liver disease, is progressing despite medical management, or if it's a bulky disease localized to the liver, which means there is a lot of disease in the liver and we don't want it to keep progressing, and there is a role for liver-directed interventional therapy in those patients. So regarding the embolization modalities, and embolization means getting into the hepatic arteries and blocking the blood supply to these tumors off, and so there are different ones. There is transarterial embolization, which goes by TAE, and then there is TACE, which is transarterial chemoembolization, the TACE treatment. So in the TAE, we are blocking off the blood supply by injecting small particles which go into the smaller arteries which are supplying these tumor, and the tumor dies off because we are cutting off the blood supply to the tumor. However, there is the chemo component, the C component, which it's there in the TACE treatment, in which the particles, it has a dual purpose. It is cutting off the blood supply to the tumor, and it is also has the chemotherapy with it. And that chemotherapy is a very localized chemotherapy to the tumor itself in that liver, and it doesn't affect the rest of the body like your conventional intravenous or systemic chemotherapies. And then there is ablative therapy, which is like a direct ablation of the tumor. And the role is small, which means ideally less than 3 centimeters. Oligometastatic, ideally less than 4, less than 5. Liver lesions. And what that entails is we go directly with our probes. We can kill the tumor either with thermal ablation, which is putting a probe into it guided by ultrasound or CT guidance. We get to it, and then either we use same technology as your microwave, and we heat it and we kill it, and we take a small margin so it does not regrow in that area. And the other is cryoablation, which is not often used. It has which means freezing the tumor, which has some roles in the liver, but the usual is the microwave, the heat-based ablation. So there have been extensive, publications on this, and they have compared one liver-directed therapy compared to the other, like the TAE, the TACE, and then there is radioembolization, in which it's sort of a radiotherapy in which we are injecting, again, small particles, but these particles are staying in the arterial system, supplying the tumor and emanating a radiation. And that is called the transarterial radioembolization. So again, TAE, we are just injecting particles. TACE, the particles have the chemotherapy on them, and the TARE, which is the radioembolization, which is a very selective radiation treatment, selective internal radiation treatment, in which the particles have the radiation emanating radionuclides on them, and then that is what kills the tumor. So there hasn't been, like, based on all these publications, extensive research, like what we know is there is another TACE treatment, which is a depth TACE treatment. We do not favor that treatment in patients with neuroendocrine tumor. It's often used in patients with primary liver cancer, but again, that can lead to more side effects, so we do not typically use that treatment. So with the TAE versus TACE versus TARE, there hasn't been, like one is favored more than the other. There are some clinical scenarios where one may be favored than the other, and I'll touch base on those. So as I talked about bland embolization, chemo, or the radioembolizations, it's typically done in an IR suite where we have like the ultrasound access. Ultrasound we use to get into an artery into the groin or into the left wrist, and the goal is to use our catheters and wires and get to the artery, which is selectively supplying the tumor, and then we use that to inject. We confirm we can do CTs on the table, we can do angiograms, which means injecting dye into the arteries and seeing which one is supplying the tumor, and we very super selectively select using small catheters and wires the artery supplying to the tumor itself, and then we inject one of these three treatments based on which was chosen for the treatment. It's typically, so here's a diagram in which it's showing like accessing an artery in the groin, and then we are passing catheters and wires, and the green these spheres are shown as the tumors, and we are showing that, and here is the injection of the small particles into the arteries supplying the tumor, and that's how the tumor cuts off the blood supply, which is the usual mechanism in TAE and TACE, and the TARE is mostly, it's less of a cutting off the blood supply, it's more of a radiation effect. So, like I mentioned, liver is sort of like special in that it gets like blood supply from two different sources. One is coming from the portal vein, which is the majority of the blood supply, and one is coming from the hepatic artery, which is the minority of the blood supply. However, tumor, when it goes to the liver, the neuroendocrine tumor especially, it is getting most of its or all of its blood supply from the hepatic artery, so we can go safely and treat that tumor using cutting off its blood supply from the hepatic arteries. So, and then the rest of the liver is mainly supplied by the portal vein, and that's why we are able to save the rest of the normal liver, which is very important for these patients, to not, because they're getting multiple treatments over time, we want to save as much normal liver as we can for any future treatments. And the treatment itself is performed under conscious sedation. We inject like IV medications at the time, and then some patients may fall asleep, but again, during the treatment, we may ask the patient to hold their breath so we can image effectively and be very selective in our treatment. And depending on how large of an area we are treating in the liver, it can be a same-day discharge. We just watch. If we access the groin, we typically close that hole that we use to enter the artery with a plug or with a suture, and then we watch for a couple hours, make sure there is no swelling at the groin, no hematoma or bruising or anything, and then patients can go home the same day, or we may keep them overnight if we are treating a large area, because then they can be symptomatic, they can have more pain, and we want to make sure their pain is well controlled before they're discharged home. So this is a diagram of bland embolization. Like, this is how the beads look like, and the beads come in like pre-manufactured, in different sizes, which could be like 100 to 300 microns, 300 to 500. Like 100 to 300 microns is a common size that we use to treat this tumor, and again, based on different articles, it can range from all the way from 45 to 500 microns, and then we get to the artery and we inject it, and the embolic effect is ischemia, which means the cutting off the blood supply, and that's how the tumor responds to the treatment. So that was the TAE, and this is the TACE, in which similar sized beads. So as I mentioned, like, we do not use the drug-eluting beads, which is used in primary cancer, but again, in these patients, in patients with metastasis from neuroendocrine tumor, we use conventional TACE, which means there is an oil, which is lipiodol, which also has the embolic effect similar to the beads, and it also works as a carrier for these chemo beads, and it tells us where exactly it's going while we are injecting it, so we can be very super selective and avoid the normal liver. So this is how mixing it looks like, and it has the dual mechanism, which is cutting off the blood supply and also keeping that chemotherapy in that area and killing that tumor very super selectively and relatively sparing the rest of the body from the effects of chemotherapy. And then we have the radioembolization, the Y90 treatment. Y90 is the name of the radionuclide, which we inject, and it goes, essentially it goes to the same area that the beads were going, but rather than the cutting off the blood supply, which is a minor effect, it is going to emanate radiation very selectively in the liver, and it penetrates only up to 1 centimeter in the liver and sparing the rest of the body from the radiation and rest of the liver from the radiation, and that's how it affects and kills the tumor. So these particles are extremely small, smaller than the typical that I mentioned, the one for the TAE and the TACE, and it's essentially like selective, very selective internal radiation treatment. So with the current data, like I mentioned, like there is no like randomized controlled trials, which means the prospective studies where we see like we study patients like with different treatments, and then we don't have enough evidence to suggest one treatment over the other. There's a RETNet study, and the preliminary results of RETNet study show, again, confirm the same thing, that the TA versus TACE, there is not much change in either of those treatments. And with the retrospective data, which means studying treatments which were treated with various modalities, various embolization techniques, we know that the symptom control, the overall survival, the hepatic progression-free survival and disease control rate, and the response on imaging is pretty much the same between various treatments. And these are highly efficacious treatments. The symptom control rate in patients who are symptomatic due to their tumor spreading to the liver can range from 70 to 92%, and disease control rate, which means imaging response, it can range from 63 to 91%. And regarding PRRT, which is intravenous injection of a radionuclide which goes and binds to the selective receptors which these tumors manifest, and because that is also radiation therapy with a different kind of radionuclide. So, and there is a question of like radiotoxicity, which means radiation-induced liver disease. So at this time, like there is no evidence for suggesting in which order we do it, and like the indications for them are different. And so with the various embolotherapies, with the TAE and TACE, it leads to it cuts off the blood supply more effectively than the Y90, so it leads to rapid tumor necrosis, which leads to early symptom response, early imaging response, which you can see in a month or so, like that the tumor has responded really well on the imaging. And however, because the tumor is dying so quickly, it leads to what we call a post-embolization syndrome, which releases some vasoactive substances into the blood circulation, which can lead to symptoms like nausea, vomiting, can lead to localized inflammation, lead to pain, and low-grade fever. And there is a high risk of releasing all those vasoactive substances that the neuroendocrine tumors can produce, and there is a high risk of those symptoms worsening before they improve. And if there is a large tumor burden because of the risk of worsening the symptoms and worsening carcinoid symptoms, it's better to perform it in stages. Like we treat some part of the metastasis at one time, and then we wait 4 weeks or so, see how the liver function does, see how the symptoms are, and then we do the next part of the treatment. And like I mentioned, we are occluding like the main blood supply to these tumors, and it's hard to get into those arteries and do the same thing again. However, with Y90, we can do it again if need be. And if there is portal vein thrombosis due to one reason or the other, which some patients may have, the Y90 treatment is known to be safer than TAE and TACE because we want to preserve the blood supply to the normal liver, and the majority of the blood supply to the normal liver is already gone due to the portal vein thrombosis. Then we do want to preserve that. And there is a low risk of long-term hepatotoxicity, which means toxicity to the liver, having treatment-related liver disease, which is higher in the Y90 treatment because we are injecting, because the normal liver, eventually, if we are treating it again and again, it can show changes of cirrhosis, which means chronic liver disease. So, and like we talked about TAE versus TACE and Y90, so less chance of any symptom worsening with the Y90 because it's slower tumor dying, slower symptom response, and the imaging response, which means how it shows on the MRI, may take up to 3 months to judge, yes, that the patient has responded to the treatment. And again, like the post-embolization syndrome that I talked about and the carcinoid flare, all of those are lower risks with the Y90 treatment because of just the mechanism, how it does. And another word about the Y90, because it does not lead to as much worsening of the symptoms. You can treat, like, if a patient has a disease in like one lobe or the other lobe of the liver, we can treat, or both lobes, we can treat a lobe at the same time. And then if we were to treat the other lobe, we typically wait 6 weeks or so, we see if they have tolerated the treatment well, and we treat the other lobe. And a word about like the sphincter of Oddi, which is the biliary sphincter, like the liver produces this bile and it's excreted into the bile through, and the sphincter of Oddi does not let any of the bile, like bacteria or organisms, to colonize the biliary tree, which is in the liver. And if it's compromised, which can happen in some patients who've had some sort of a biliary surgery related to stones, or it can happen, or patients who've had a surgery in which they have connected the bile duct directly to the bile, like hepaticojejunostomy. And in those patients, by definition, their biliary tree is colonized with bacteria, and they are not symptomatic from it. And the Y90 treatment is safer in those patients, lesser risk of infection compared to the TAE and TACE. And it's easy to get back into these arteries and treat again, and safer in portal vein thrombosis. So a few of these examples. So this first patient on how we use such treatments for patients. So there's a 75-year-old male patient who had a pancreatic neuroendocrine tumor with a disease going to the liver, and it was grade 2 tumor. They were on lanreotide. However, the liver disease was progressing despite the treatment, and they were symptomatic. They had severe diarrhea, like 12 times a day. The 5-HIA, which is a metabolite which we can check in the urine and see how metabolic active the tumor is, it was mildly elevated at 69. And here's a CT scan for that patient, and we are looking at the CT scan. It's like a patient lying on a CT table. We're looking from the foot side, and these would be slices, progressive slices through the upper part of the abdomen. And as here, the middle structure that you see is the heart, and the right lung and the left lung. This is the right side, the front, the left side, and the back of the body. And the heart is showing like the IV contrast and the IV dye, which has been injected at the same time. So these would be the scan of that patient, and here we are seeing the liver, and all these spherical structures which are measured are the metastatic disease to the liver. So this patient we treated using a transarterial embolization, and when we get into the arterial system at the time, we can inject the arteries with dye and do intraprocedural catheter-directed CTA, which essentially looks like the CT, but we are injecting the IV dye directly into these arteries, and which helps us map the arteries even better and select the arteries even better to help get to those and spare as much normal liver as we can when we are treating these tumors. So this was the map intraarterial CTA, which showed us which arteries we need to go into. And then we select a smaller catheter, and we get there, and then we do our angiograms, which means injecting the arteries and taking live X-rays. This is how it looks like. And here you can see the tumors lighting up here and here, more than the liver and earlier than the liver. And then we can do like cone beam CT, and then which is again a special kind of CT which uses the X-ray, like the spin of the X-ray machine, and we want to be absolutely sure what area we are treating. And this was the cone beam from the superselective artery that we went on to treat, and showed like what part of the liver we would be treating. And after the treatment, the diarrhea essentially resolved for this patient after the first treatment, and the remaining disease in the liver was treated in staged fashion. And this is a MRI for that patient, which again would progressive slices through the body. And here we are seeing that most of that tumor is necrotic, which means it's not taking up the dye as it was before on the CT scan. This is another patient, a 75-year-old female patient who had a neuroendocrine tumor of the small bowel, and they had liver metastasis, and it was grade 1. And they had symptoms from as you can see, the large size of this tumor, which is pushing on the liver capsule, which is the lining of the liver. And they have another tumor here. And this is the radionuclide scan, and which shows like uptake in both of these tumors. And they had symptoms despite being on octreotide treatment. And this is an angiogram for that patient at the time where we are injecting IV dye through the catheter, through the groin axis. And here we can see the tumors taking up the dye, the large tumor that I just showed on the CT scan. And it was treated with bland embolization, which means like particles just to strangulate the blood supply. And here is a comparison. This is before the treatment. Here you can see compared to the normal liver, it is also taking up dye. And then this is after the treatment. Here you can see after treatment of this large tumor, it has shrunken in size, and it is not taking up IV dye at all, which shows that it has necrosis and it is in the process of dying. So for this patient, diarrhea essentially resolved. They had occasional soft stools, and the other lesions were not treated. This is another patient, a 60-year-old female patient who had a neuroendocrine tumor in the small bowel. They had disease spread to the liver and the lymph nodes, and it was a grade 2 tumor, symptomatic with diarrhea and flushing, and they were progressing despite multiple treatments. And the symptoms were palpitation, shortness of breath on exertion, flushing and diarrhea, which are common symptoms in functional tumors. So this is a CT scan for the same patient, and here you can see they have disease in predominantly left lobe disease, however, disease throughout the liver. And this patient was treated with transarterial therapy. This is the intraprocedural catheter-directed CTA, and here we can see how we can identify the selective arteries which are supplying this tumor. And then considering the large tumor burden in this patient and multifocal tumors, it was treated by staged lobar radioembolization, in which the injected beads had radiation on it, and the treatment was spread 6 weeks apart for the patient to tolerate the treatment well. And this is at the time of the first stage treatment, in which we can see all these tumors lighting up on the scan. And then after the treatment, their symptoms essentially resolved, except for diarrhea, which showed significant improvement. And here we can see through the CTA that all these tumors are showing necrosis, which means shrinking in size, and also less enhancement, which is less taking up of the dye on the CT images. So for the future, there has been we may need if the patient would benefit for like embolization, which is treatment and systemic therapy, if that would be more beneficial for these patients, and also what about PRRT, which is injection intraarterially rather than injecting the TAE, TACE, or the Y90 beads. We can inject a PRRT like transarterially through the arterial system, and if that would help these patients better, and we need more research on that. So, like I talked, like the embolotherapies have similar efficacy, but again, different side effects and toxicity profiles based on the individual patient, their prior surgeries, their symptoms. One treatment may benefit, and their choice, one treatment may benefit them more than the other. And we typically tailor this to the patients, and we need more research about adjuvant treatment, adjuvant systemic therapy, and a role of any intraarterial PRRT. Thank you for your attention.